Okay, I think we'll get started. So thank you for joining us. And for those of you who haven't been able to join us before, let me introduce myself. I'm Kelly Metcalf, and I'm a scientist in the Hereditary Breast and Ovarian Cancer Group at Women's College Hospital. And we're thrilled to be able to bring you these seminar series. It really is our goal to bring you the most recent research results so that you can use them in the management of your cancer risk and helping you to navigate some of your decision making that might be happening. So for those of you who have been joining us, you probably all know Joanne Kotsopoulos as well. So please let me introduce her. Dr. Joanne Kotsopoulos is a scientist in our group at Women's College Hospital. She's also an associate professor in the Della Lana School of Public Health at U of T. And her research really focuses on cancer prevention and some of those modifiable risk factors that may or may not exist when we're thinking about women who have genetic predisposition to developing cancer. So I think that this is a very timely topic, especially as we're testing more and more young women. Thinking about how to manage that cancer risk if you're a young woman who has been told that you have a BRCA1 or BRCA2 mutation. So welcome, Joanne, and thank you for joining us today. Just a reminder that if you have questions, please enter them in the Q&A box at the bottom of your screen. And I will bring those questions to Dr. Kotsopoulos at the end of this presentation. And so I will go on mute and I'll turn my camera off, and I'm going to leave it to Joanne to present to us some of the latest research in this area. So thank you and welcome, Dr. Kotsopoulos.
Thank you, Kelly, and welcome everyone. I'm hoping you can see my screen. We were having, of course, technical difficulties before we got started. So a lot of what I'm going to be talking about today might be a little bit of a repeat or have a few common themes based on what we've been talking about over the past almost 2 years of sessions that we've been having virtually. But just to quickly overview my presentation, I'm going to give a little review of the cancer risks, the main cancers we talk about when we're referring to women with the BRCA1 or 2 mutation and the clinical management of these women. And then I'll provide a little bit of an overview of the most up-to-date findings for exogenous hormone use. This means hormones that we use typically, such as hormonal contraceptives and hormone replacement therapy, and how these impact risk of disease, the role of reproductive factors. And then I'll be providing an update of a very current and recent analysis looking at the impact of oophorectomy on all-cause mortality. So again, this may be a repeat for many of you that are here, but when we talk about the management of hereditary breast cancer, we know that screening with MRI imaging and mammography is available to all women who are at high risk because of a genetic predisposition. Many of you will have had a frank discussion about risk reducing or preventive bilateral mastectomy, so removing unaffected breasts before cancer develops. And there's also consideration of risk-reducing agents. So things we think about are tamoxifen or aromatase inhibitors. But like I'm going to talk about in a few slides, there's very limited evidence for BRCA mutation carriers specifically. And we've also learned through the research of Dr. Metcalf and the team that very few women are using these drugs for chemoprevention. When we think about ovarian cancer, what we see right away is that surgical prevention is the only way to prevent this very rare but fatal disease. This disease is rare in non-carriers, but we know that the lifetime risk is very high in BRCA1 and BRCA2 mutation carriers. And so bilateral removal of the fallopian tubes and ovaries is strongly recommended. There's age-specific recommendations based on the mutation. And this is really important because unlike for breast where we have MRI imaging for screening and early detection, there's no effective screening modalities for mutation carriers for ovarian cancer specifically. And something that I'll return to again later on is this idea of self-injectomy or fallopian tube removal. And the fact that this is not standard of care for preventing ovarian cancer right now. So those are the guidelines, but what are high-risk individuals actually doing to prevent disease? So a lot of the work that I'm going to be talking about, and sorry if this is a repeat, is really, I'd like to review where all our data comes from, because many of you contribute to this data. And without this contribution and ongoing commitment by our mutation carriers, we could not present most of the work that our team does. So many of you may know this study as the risk factor analysis study. This is the largest international longitudinal study of high-risk women. And the way we collect data is by research questionnaire that's collected usually at the time of genetic testing. And then we're often contacting you and bothering you to update us on any information on various exposures and outcomes. But this is really important and a very important resource for our team. And now we have over 18,000 women with the BRCA1 or 2 mutation enrolled from across the globe. And this data has become critical for us to continue to conduct our research program and improve upon the care of high-risk individuals. So what Dr. Metcalf recently published was what are mutation carriers that are enrolled in our cohort actually doing to help manage these very high risk of developing disease. So what we see here on the left side is that about 70%, so a large proportion, are having preventive oophorectomy. And so this is great because we do want to prevent ovarian cancer. On the right side, what we see is that many women, and again, more than 70, up to 80 or 90% are undergoing regular screening with MRI and mammography for early detection of breast cancer, which is great. But again, we know that imaging does not prevent disease. We just want to detect it at an early and hopefully more curable stage. But what we see right here in the middle is that uptake of mastectomy, so preventive mastectomy or use of these chemo prevention drugs is quite low and has remained very low over the decades. So when we talk about chemo prevention, as I mentioned, we think about tamoxifen more frequently because this is the one drug that can be used by premenopausal women. And when we think about mutation carriers, we know that cancers, especially in BRCA1 mutation carriers, these cancers tend to happen early in their lifetime, often before menopause. And a lot of the work that's actually been done to help inform the guidelines for use of tamoxifen in high-risk women came from a pretty old study that was published quite a while ago, but it only included 288 women that had a mutation. And although, sorry, there were only 20 women with a mutation enrolled in the study. But what they found was that especially for BRCA2 mutation carriers, there was a decreased risk of developing breast cancer among women who had used tamoxifen, but no strong impact in BRCA1 mutation carriers. But a lot of the evidence that has guided the use of tamoxifen is based on studies by our team and others that have shown that tamoxifen prevents a second breast cancer from happening, which we know is a contralateral breast cancer. And so this is why many of the guidelines still continue to include tamoxifen as an option for high-risk women. So we'll be talking a lot about risks of disease, and to keep our statistics simplified, anytime we talk about an increased risk of disease, we see anything that is above 1 and anything that's protective is below 1. We also talk about significance. So we recently took a look at our database to really take a really close look at tamoxifen use and to see what was happening in our cohort of 18,000 women. So among the women that were eligible to be in the study, we had almost 3,500 women who had never used tamoxifen, and 12% had developed breast cancer. There were only 231, so very few women are actually using tamoxifen to begin with, and 10% developed breast cancer. So even without doing strict statistics, we can see that we're not exactly confident that tamoxifen is preventing breast cancer in high-risk women. But we can't think about BRCA mutation carriers and not think about ovarian cancer. So a lot of the data that I'll often present the breast cancer risks and then the ovarian cancer risks with the exposure. So something like tamoxifen, we're not sure if it's a risk factor for ovarian cancer. In an earlier report that was conducted by our group, we saw no impact on ovarian cancer risk. So when we think about tamoxifen, there's some there's interest in this because tamoxifen is not only used for chemoprevention, so preventing breast cancer, but it's also used to treat a breast cancer. And this is very, because of the high incidence in mutation carriers, many women will have been exposed to this drug. But based on our work so far, we see no impact on ovarian cancer risk. So that's tamoxifen, and we're still working closely with our data to see if we can make a more definitive conclusion on the impact on breast cancer risk. But what about something more commonly used? So oral contraceptives, and this is something that's used worldwide. It has a purpose in preventing, it has a purpose in not only preventing pregnancies, but also is used for several other premenopausal conditions. So what is the association between oral contraceptive use and BRCA breast cancer? So a recent report took all the data that has been published in the topic and really took a close look at this question because there was a lot of inconsistency in the literature regarding the use of this drug and risk of developing disease. And unfortunately, when you look at all the data combined here, and there have been several studies in BRCA1 and BRCA2 mutation carriers by our team and others, there is a lot of inconsistency still. But when we look at this hazard ratio, again, when we look at any risk above 1, we're still seeing that the data is pointing towards a potentially increased risk of developing breast cancer among mutation carriers who use oral contraceptives. Now, the risk of developing disease due to the mutation is substantially higher than the extra added risk of using oral contraceptives. But this presents a predicament, and we're really trying to conduct a large collaborative study with other sites worldwide to try to really answer this question, because we know many women opt for oral contraceptive use. And another reason why this is important is that when we look at the literature for ovarian cancer specifically, we do consistently see a significant protective effect of oral contraceptives in decreasing the risk of ovarian cancer in mutation carriers. And we see about a 40 to 50% reduction in risk of disease when we look at all the data combined. Now it's stronger, the effect is stronger with more recent use, and it persists even after someone discontinues use. And this still remains the strongest protective effect for women with a mutation. And the same exists for non-carriers. We know that oral contraceptives prevent ovarian cancer in general. So that's the data for oral contraceptives. But what about other contraceptives in cancer risk? We know that there's been a lot of changes in the types of contraceptives that are available with the use of IUDs, or what's referred to as non-oral long-acting reversible contraceptives. So injections and implants. And even when you look at the data in non-carriers, so the general population, there's still limited evidence because these are really contemporary hormonal contraceptives. And we don't have a lot of long-term data looking at cancer outcomes. And so it's not surprising that the impact on cancer risk and mutation carriers is also not known. But one of our recent trainees took a quick look, not a quick look, she took a look for her for a graduate degree. She did a really in-depth study of the women who had used these other contraceptives and looked at the risk of developing ovarian cancer. And this is important because we know that oral contraceptives are significantly protective. So we want to know, is there a role of these other implants, injections, and IUDs on the risk of developing disease? And something that I failed to mention in the beginning is that we're now understanding more and more about the pathology and the development of ovarian cancer and mutation carriers. So we know that women can be at risk of developing fallopian tube or ovarian cancer, and these are often grouped together. So keeping in mind this odds ratio of 1 meaning no effect and a odds ratio below 1 as being protective, we can see right away that when we look at any sort of contraceptive, whether it be oral contraceptive, an implant, injection, or IUD, we still continue to see a protective effect of contraceptive use on ovarian cancer risk. So this is really important. And although there were very much fewer women who had used these other contemporary methods, we still continue to see a reduction in risk. So again, at least this is pointing towards a protective role of contraceptives in mutation carriers for ovarian cancer specifically. But we still need to figure out the breast cancer association, and that's something that's underway right now. So what about hormone replacement therapy? And this is really important because we know that women with a mutation are advised to have their ovaries removed at a very young age. And so many women are forced into surgical menopause well before the natural age of menopause. And so there's really an important role of hormone replacement therapy in trying to mitigate or avoid some of these adverse effects of surgical menopause, including menopausal symptoms and other long-term comorbidities that may occur with early menopause, such as a decline in bone health and cardiovascular health. So in a study by our team that looked at the impact of hormone replacement therapy after oophorectomy and breast cancer risk, we decided to focus on BRCA1 mutation carriers, and this was really just due to the sheer number of women in our cohort. We have many more BRCA1 mutation carriers than BRCA2, so we decided to keep the study more focused. And this is important because when we look at the literature in non-carriers, the large HRT, so hormone replacement therapy trials, did show an increased risk of breast cancer in women who used progesterone containing HRT. So we wanted to see if the same was true for our carriers in our cohort. So we looked at the breast cancer incidence over time among women who use estrogen alone. Actually, this should say no HRT. Sorry, this is incorrect here. The blue is any HRT and the yellow is no HRT, so no hormone replacement therapy. And we look at these curves over time, over 10 years of follow-up, we don't see a striking difference. So the breast cancer incidence in BRCA1 mutation carriers, whether you did or did not use HRT, was similar. But when we looked at estrogen alone versus estrogen and progesterone containing HRT, which is shown here in the blue, we see that more women develop breast cancer over time in the E plus P group compared to the estrogen alone. So this again is pointing towards a harmful role of progesterone containing hormones. And this is really similar to what we see in the non-carriers also. And what was even more important when we think about our mutation carriers is that the risk was even more pronounced. So again, we see more of a separation in women who used HRT and had an oophorectomy under the age of 45, which is often the case for BRCA1 because we recommend surgery around the age of 35 to prevent ovarian cancer. So I think in summary, you can see that although any HRT did not impact breast cancer risk, the progesterone containing HRT was associated with a higher risk of breast cancer. So we can't think about hormones and not think about ovarian cancer. And we have looked at HRT and ovarian cancer in our data set, but again, this was a very small number of women. And what we found was really no significant impact on risk of ovarian cancer with the use of hormone replacement therapy. Now, whether or not this is a valid finding, the study is quite old. It was published in 2005. We know that in non-carriers, HRT does increase the risk of disease. Again, this is an important question, but what we have to keep in mind is that most mutation carriers will have their ovaries removed. So this becomes less and less of an issue. And instead, we need to really think about the breast cancer risks for women who are having an oophorectomy using HRT, but still have their breasts intact. So you can tell that this becomes a very complicated clinical question. So those are the risks with hormones. And I know it seems like a lot of information, but I'm really trying to keep it as simple as possible. But what about other modifiable factors? And I have modifiable in brackets. And I think we know from the literature that we hear a lot about in non-carriers is this idea of healthy body weight, physical activity, using other commonly used medications such as aspirins or other anti-inflammatories, and then the role of reproductive factors such as breastfeeding and childbearing. So instead of going through every study that's ever been completed, I've tried to summarize some of these risk factors by site and what we and others have found for BRCA1 breast cancer specifically. And then in the next slide, I'll show the risk factors for ovarian cancer. So I've grouped these into 3 columns. We have risk factors, we have protective factors, and then we have factors that seem to not play an important role. So let's start in the middle. We know that bilateral preventive mastectomy or risk-reducing mastectomy is the most effective way to prevent disease in carriers. So anything we're talking about in this conversation today is really after taking into account preventive surgery, because that will be the most effective way of reducing risks of breast or ovarian cancer. We've also shown a protective role of breastfeeding and early physical activity. And here in the pink are some things that we don't know about very much yet. The use of these common medications such as analgesics or aspirin and statins, and something called denosumab, which is an osteoporosis drug, and I'll return to that later on. So we still don't know about the impact of these other medications. Some risk factors, our team has shown that smoking increases the risk of BRCA breast cancer, a later age at menopause. Again, the contraceptive use here in pink, because we're still not 100% clear. Progesterone containing HRT and weight gain, all are risk factors. We've seen no impact of alcohol on increasing risk. Similarly, for ovarian cancer, again, above and beyond oophorectomy, which is the most important way to prevent disease. I already mentioned the important role of contraceptive use. We've showed an decreased risk, significant decreased risk with breastfeeding, an increase with smoking and weight gain. But again, we have a lot of unknowns with these commonly used drugs, aspirin and statins, with fertility treatment, talc. And although we saw no effect of HRT, our study was limited, and we need a little bit more data to clarify that. So those are some risk factors that may increase or decrease risk among women with a mutation, but really our group is really starting to focus a lot on mortality and survival, the survival experience of high-risk women, because we don't only want to prevent disease from happening, we really want to reduce death or reduce mortality in women with a mutation. And this is when the surgery becomes a really important component of care. And I think many of you will know that oophorectomy is really strongly recommended to BRCA1 and 2 mutation carriers. And a study published in 2019 was able to compare the mortality experience or how many women died who were only having screening with ultrasound compared to those who had an oophorectomy. So this study was conducted in Europe, because many of you who are living here in Canada or North America know that we no longer do screening for ovarian cancer because studies of ultrasound imaging and CA125 have not been shown to be effective in many trials that have been conducted. So there is no more screening right now for the early detection of ovarian cancer. But using the data from our European collaborating sites where screening is still available, here we can see that there were 1,196 women undergoing screening every year. There were 73 ovarian cancers diagnosed and 30 deaths. However, among the women who underwent preventive oophorectomy, this included 659 women, 12 cancers were diagnosed. But what's interesting here is that many of them were occult. So they were diagnosed at the time of their preventive surgery, which can happen, especially among women who are having surgery a little later than the recommended age. However, only 2 women died. So we see a significant reduction in death among women who have an oophorectomy compared to those who are undergoing screening. And so we recently conducted an updated analysis looking at the impact of oophorectomy on cancer-specific and all-cause mortality in our large risk factor cohort. And again, this is an ongoing question because not only are women, are a high proportion of mutation carriers having this surgery, we know that from the general
But I think we've been hearing a lot today about some of the risk factors, especially for those who are younger women, and thinking about some of the reproductive choices that one may make, when to time a preventive surgery, if you're considering that. And if you're not considering preventive surgery, what some of the other options are to help you reduce your risk. So she's responded, she is having computer troubles, so we will continue to wait for her. I did see a couple of questions that maybe I will answer as we wait for Joanne. So there is a question about ultrasound screening for breast and ovarian cancer. And I think Joanne has just presented some very compelling evidence about the ineffectiveness of ultrasound screening for ovarian cancer screening. So we know there's about an 80% reduction in death when we're comparing preventive oophorectomy to ultrasound screening in women with a BRCA1 mutation. So by having a preventive oophorectomy, you're reducing your risk of dying by 80% compared to a woman who chooses to have ultrasound screening of her ovaries. So that's, I think, very compelling evidence about why we're not doing ovarian cancer ultrasound. As for breast cancer ultrasound, ultrasound is not used as a screening modality. It is used in the diagnostic period when something is found on other imaging like an MRI or an ultrasound. So Joanne, we were just starting to answer some of the questions while we waited for you. I said,
I'm so sorry. I came to the hospital so I wouldn't have technical difficulties and the Wi-Fi went out for a minute.
Okay, so continue on, Joanne. I will mute myself again.
Oh my, I'm so sorry, but let me just get a minute to, sorry, everybody.
That's okay. I said, we're all used to this 2.5 years later. It's
Yeah.
happened to us all.
Okay, I think I was here, oophorectomy and all-cause mortality. Okay, so I feel like I keep repeating myself, but I think this is an important point that oophorectomy has a very important role for primary prevention of ovarian and fallopian tube cancers. And something that Dr. Kelly Metcalf will talk about more, I'm sure, in the future is, and has spoken about already actually, is the important role of oophorectomy after a diagnosis of breast cancer. We know a better survival in women who have had a breast cancer diagnosis and then undergo oophorectomy. And our team is really interested at the impact on non-cancer outcomes associated with early surgical menopause. So we want to prevent ovarian cancer, a fatal disease with no screening opportunities, but we also don't want to cause more harm. So we want to accurately estimate the risk and benefit of oophorectomy. So the only way you can do this is to do a prospective cohort study. So where we follow women over time after they've had an oophorectomy. So that's what we did. There were 3,179 women in the study. 2,108 underwent preventive oophorectomy, 1,071 did not. So again, these are all mutation carriers from our large study. If we go straight to the bottom here, we see how many women have died so far. 6.2% of the women have died. But what we see right away is a proportion of women, so the percentage in brackets, 4.4 who had an oophorectomy died, compared to 9.7 who did not. So right away, we see a striking difference in death rates, an overall percentage of women who have died, who have had and did not have an oophorectomy. And I've listed the most common causes of death here. And right away, we see in the no oophorectomy group, most died of ovarian cancer, followed by breast cancer. Whereas in the no oophorectomy group, we see less causes of death due to ovarian cancer and breast cancer. What is also important, and it might be hard to see because there's a lot of numbers here, is that the number of other cancers was not substantially different between the two groups. And so we're not seeing more cardiovascular disease, which we were worried about, other cancers. There's a difference in the number of peritoneal cancers, but Dr. Narod will be talking about that in the next session. But what's important is that we're preventing the cancers we want to prevent, decreasing all-cause mortalities in the oophorectomy group. But right away, we're not seeing no impact on other diseases. And as our cohort ages, we'll be able to see if there are differences in other disease incidences, such as osteoporosis and diabetes. So again, when we look at the risk of dying, these hazard ratios that I keep talking about, and hazards below 1 being important and protective, right away, women who have had a oophorectomy had a significant reduction in risk of dying. And from a statistics standpoint, we see a lot of zeros on this side, which means this was very strongly significant and strongly protective. So oophorectomy decreased the risk of dying in these women with a mutation. And the age at which the woman had an oophorectomy, it didn't matter, but again was stronger if you had it younger in age or at the age appropriate recommendations. So a dramatic 72% reduction in risk of dying. I'm going to skip over some of these slides. So something that you might be hearing about a lot, or if you're a younger mutation carrier that's speaking with their gynecologist in recent days and considering preventive surgery, is this idea of salpingectomy. And that means removal of the fallopian tubes. And we know that the fallopian tubes are very close to the ovaries. And now we're seeing more and more detailed evaluation of fallopian tubes and ovaries at the time of oophorectomy. We know that some cancers may originate in the fallopian tubes and not necessarily the ovaries. But from a mutation carrier standpoint, we still group these together. And we're really interested in the role of salpingectomy in preventing cancer and preventing death. So like I just mentioned to you, oophorectomy prevents disease, but also prevents a woman from dying. So there is a role of salpingectomy in women at baseline population risk. So this is in the general population, and now they offer fallopian tube removal instead of tubal ligation as a contraceptive method, and also removal of fallopian tubes at the time of other benign surgeries, such as hysterectomy, because there is potential to prevent cancers from arising in the fallopian tubes. And it's cost effective, it's actually simple, but we're still trying to understand if it's going to prevent disease and death. In non-carriers, there's some emerging evidence that it might, but again, these are all cost-effective analyses, so they're simulations. And this is fairly a new routine practice that started in 2015, I would say. And it really began in Canada when we think about opportunistic salpingectomy. It started in British Columbia. And so a lot of countries and provinces are opting for salpingectomy for non-carriers. And there is a role for non-carriers, but it is not standard of care to undergo risk reducing surgery with salpingectomy alone. Although there is this interest, and there are some clinical trials looking at a 2-stage surgery for prevention of ovarian cancer, where the tubes are removed at an earlier age, so perhaps at the time of childbearing when you would have had a tubal ligation, but then having the woman come back to remove her ovaries within the recommended time frame. But that is only being undergone within a clinical setting, and clinical research projects are evaluating this. And Dr. Metcalf, Dr. Narod, and myself are also looking at outcomes following salpingectomy in our cohort, because we know that some women are electing for salpingectomy. And this may be the women that are opting for the 2-stage approach to prevention, which is possible, or for women who are just refusing to have an oophorectomy, but will at least consider removing their fallopian tubes. And so this is ongoing with our team. It was funded by CIHR. And many of you may have recently received invitations to participate. So I think we've clearly demonstrated that oophorectomy is an important component of the clinical care of high-risk women, strongly recommended worldwide. But we can't ignore the non-cancer outcomes following oophorectomy. And given the time, I'm going to quickly go through these because I think I presented this already. It's not surprising that oophorectomy impacts upon menopausal symptoms. These seem to be a little bit more dramatic in women who are premenopausal at surgery, which is not surprising. But again, HRT is important. And it's important to continue to see your clinician and your to work towards with your primary care doctor or gynecologist to manage symptoms. And it's not always a one-size-fits-all approach. And this may need some discussion and ongoing discussion after oophorectomy. Oophorectomy does result in a decline in bone mineral density. It's much more striking in premenopausal women. So here we can see 0 is baseline. These are postmenopausal women seeing less of a decline in bone health after oophorectomy, but significantly more in premenopausal women. And again, this is when HRT and diet and lifestyle can significantly impact, because we see less of a decline in women who do use hormone replacement therapy. So those are some of the negatives, but we also have seen, we've also evaluated some other outcomes, because in the literature, there's some interest in the impact of oophorectomy on depression and cognitive decline. Importantly, we've seen no impact of oophorectomy on an increased use of antidepressants in our cohort. And many of you may have been participants in our online cognitive assessment study, where we had mutation carriers who were enrolled in our risk factor study also do an online cognitive assessment. And again, we saw no impact of various factors on cognitive assessment. And in fact, women who had an oophorectomy actually had a higher score. And other factors were also associated with a higher cognitive score. So just to summarize, I think it's clear that lifetime risk of breast and ovarian cancer in women with the mutation is high. We need to really manage the risks for both diseases, and it's an important balancing act. There is a profound impact of oophorectomy on death in these women, but we can't ignore the adverse outcomes that impact upon quality of life. And there's an important role of mitigating these outcomes. For those of you who are fortunate to be seen here at Women's College, we have an amazing aftercare clinic where there's clinical care of women post-oophorectomy to help manage some of these symptoms. But again, we have a lot of unanswered questions. Some of the data I presented were only for BRCA1 mutation carriers. We need to know if some of this is valid for BRCA2 mutation carriers. We need to understand if fallopian tube removal surgery will impact upon risk or death in high-risk women. Something that I didn't really talk about, but it's important when deciding on preventive surgery, is whether hysterectomy is necessary. Should we be removing the uterus at the time of oophorectomy? Other ways to manage menopausal symptoms is important when we think about women who have had a diagnosis of breast cancer, because they are not eligible for using hormone replacement therapy. So there needs to be consideration of other non-hormonal options. And we can't forget about effective screening. There's a lot of interest in trying to still identify better ways to screen for ovarian cancer and novel prevention options. So are there any medications we can repurpose that already exist that may potentially impact upon risk? So again, we're a big team of scientists, genetic counselors, research staff, trainees, and several collaborators across the globe, and many of you participants that really play an important role in conducting this study. So I want to leave time for questions, so I'm going to stop there. And thank you for listening. And I'll stop my sharing.
Thank you so much, Dr. Kotsopoulos. So please, if you have any questions, I know it was a whirlwind of information there, and I think there's probably something that everyone could take away from this talk today. So please, if you have questions, put them in the Q&A, and I can ask them on your behalf. So Joanne, one of the slides talked about early physical activity in terms of having a protective effect on breast cancer risk in BRCA1 and 2 carriers. Can you describe what early physical activity might be or look like?
So we evaluated physical activity early in adulthood and early in adolescence. So we had queried women between 12 and 18 years old, and I know it's hard, these studies are hard because you're asking women to recall their levels of physical activity, but we did our best by using a validated questionnaire. And then we also asked during certain ages, like how active were you in grade 7, grade 8? And so we found women who were more active early on in life. So adolescence and early adulthood or around the age of 18, this was protective. But there's a caveat to these studies because the level of risk increase or risk reduction is a lot less or more, depending on what factor you're thinking about, than the genetic risk itself. So your mutation is affecting the risk more than physical activity will. I hope that makes sense.
But physical activity is part of all of our healthy lifestyles.
Yes, and maintaining we've seen an important role of weight gain and maintaining a healthy body weight. So again, this is important because fine, we're managing the cancer risk, but there are other outcomes and health outcomes we can't forget about, like cardiovascular disease and diabetes.
I have a question about denosumab, and I hope that I'm representing this question correctly from one of our participants. So denosumab use after hysterectomy and removal of the ovaries, is that something that's commonly done? And if so, are there effects of using denosumab in that setting?
So denosumab is now approved to treat osteoporosis and is also used following breast cancer diagnosis and treatment. I'm not sure if this question is about, I'm just reading the question, if it's about your doctor may prescribe it for if you have osteoporosis or an indication, but from the research perspective, there's a lot of interest in this denosumab in preventing breast cancer also. And there's a lot of discussion in the scientific community about repurposing. So that means taking a drug that exists for one indication, so in this case osteoporosis, and using it to prevent breast cancer. So if that's what you're asking also, Miriam, that is something that is of interest to our team and others. But again, this is still in the research setting and is not approved for that use.
Great. Okay, I think something that probably many women are thinking about after they have an oophorectomy at a younger age are some of the side effects that may come along with that surgery. And some of the data you presented today, Joanne, talked about bone density findings and a decrease after having an oophorectomy. So you did mention that hormone replacement therapy helps and doesn't lower bone mineral density as much as someone who doesn't take HRT. So is there still a decrease for these women who have an oophorectomy, then take HRT? What is the effect on bone mineral density, and do we see declines?
So there's more decline for women who are premenopausal women at surgery, and there's less of a decline if you use HRT. So most women who are having a oophorectomy now preventively will likely be asked or get a requisition to do a baseline bone mineral density. And most of you will probably be recommended or have the option to go on HRT. And so this will mitigate potentially, I can't say all, because there still is a small decline, but HRT will help mitigate some of these effects.
Mm-hmm. But important if you're considering this surgery to talk to your surgeon about having a baseline bone density done.
Correct. And to also above and beyond HRT, there's also, adequate vitamin. They will also recommend adequate vitamin D and calcium intake and weight bearing activity to keep bone strong.
And there's a question about how long do you use HRT for then?
So that's more of a clinical question, I would say, and you would work with your clinician because everybody's situation is different. It depends on your personal history of breast cancer or not, whether you have your breast intact, so I can't really comment personal use, but that's something you could work with your doctor to come up with an appropriate. But I think if you were, if you had a mastectomy and no previous diagnosis and no other contraindications, they could recommend until the age of natural menopause, which would be 51 to be exact.
Okay, so there's a question here too about, do we know why the uptake of prophylactic mastectomy is low?
I think I'm going to send that to Dr. Metcalf because that's her area of expertise and her paper.
Okay. I think, there is a session coming up. I think it's the November or December session that we will be discussing prophylactic mastectomy, and we have some exciting new data that we're getting ready to publish on the impact of prophylactic mastectomy on survival, which we really didn't have before. So women were being asked to make a decision when we have very good screening for breasts. So we know that breast MRI picks up these cancers at an earlier stage. We're still looking at the data to see if there will be an impact on survival. But I think in the next year, we're going to have a lot of these answers. And again, it is a personal decision. None of the international guidelines say a woman with a BRCA1 or 2 mutation should have a prophylactic mastectomy. Rather, it is an option. And that's very different than the messaging that we have about prophylactic oophorectomy, where it is a strong recommendation that women have that preventive surgery. So again, prophylactic mastectomy is more of an option as opposed to prophylactic oophorectomy, where it's a recommendation. And that's probably why it is so low. So, but stay tuned for one of our upcoming seminars. What month are we in? September? I think it's at the end of November.
It's the November session, yes.
It's the November session that Dr. John Semple and I will be presenting on prophylactic mastectomy. So join us for that, because it'll have both a clinical flavor as well as some of this really interesting data on survival, which we haven't really been able to comment on in the past. Okay, moving on to our last question. This woman has a BRCA2 mutation. She's had her preventive surgery, both breast and ovaries. She has a 23-year-old son, and we are opting to have him undergo genetic testing at the age of 25. Do you think that age is appropriate?
Oh, sorry, am I answering or Kelly? I mean, there's the guideline age of being 18 and over, but I think based on this series we've had with our genetic counselors and social workers, that is also a personal or family decision to make, and it depends on the maturity of each individual. So if you feel like your son is mature enough to I guess comprehend and process information, then it would be fine from a legal standpoint to seek genetic testing. But also from a cancer risk perspective, oh, is this the BRCA1 or 2 mutation?
BRCA2.
So because BRCA2 is associated with an increased risk of male breast cancer, I think there is a clinical relevance in having your son tested for a BRCA2 mutation. But Kelly, do you have anything more?
I think it's worth a revisit with your genetic counselor to be very informed about, is anything going to change for this person at the age of 25 if he has a mutation or if he doesn't? So, and again, maybe there will be decision-making about children, etc. It's again, a very individual decision. So there's nothing wrong with having testing done at that age for a male. But again, a very personal decision. And I think a decision to go back to your genetic counselor and have that discussion about the risks and the benefits of doing genetic testing at a particular age. Okay, so I think, Evan, will you pull up our slide for our next?
I have it here. I actually have it here.
Okay, Joanne will send. So I'd like to, first of all, thank Dr. Kotsopoulos for sharing that information with us today. It's really nice to see all of that research, those research results brought together so that we can have a very fulsome discussion about some of the risk factors and what to be thinking about if you're a young woman with a BRCA1 or BRCA2 mutation. So I thank you, Joanne, for presenting all of that today. The next session will be Dr. Narod, and he will be talking about some of the other cancers that we need to be thinking about in these high-risk families. And it's not just for women. We need to be thinking about the men in our lives as well when we're thinking about some of these other cancers. So please join us. Please share this information with your friends, with anyone you know who may benefit from hearing some of this information. Like I said, it might be very different from when you had your original genetic counseling session. The research is ongoing, like you could see today, and it's really important that we can get that information out to you as we make these discoveries, and that you can use this for your personal benefit as well for the benefit of your families. So thank you for joining us today. Please join us again next time in October. And also, if you have any suggestions for topics that you would like to see covered next year, so we're starting to think about our 2023 scheduling. So if there are topics that are important to you, please let us know. You can put them either in the evaluations that may come around to you or email us directly. We're very happy to explore some topics that you think are important, and that we can help to bring to you some of the latest evidence, get the right expert in here to talk about some of those questions that are important to you. So please let us know what those might be.
Thank you, everyone.
Have a good weekend. I guess it's Friday, so everybody have a nice weekend. Thank you.